Welcome to this session on palliative care in Parkinson disease and related disorders. At the outset, I must thank Dr. Anjum and the organizing committee of Indian Academy of Palliative Care Conference 2022. I wish it was happening in a pink city of Jaipur and we all in person, but let's hope soon the life will become normal and we will be meeting in person. So I'll request Dr. Shafi, the moderator of this session, to start the proceedings.
Yeah. Hi, good evening. Thank you so much for that, Professor Rajinder. I'm just going to introduce Prof. Rajinder Dameja. He's going to be chairing the session with Prof. Ashwin as well. So he is the consultant of neurology. He's a neurologist with special interest in movement disorders, and he's completed his fellowship from Melbourne University. Prof. Dameja is presently head of the Department of Neurology at Lady Hardinge Medical College, SSK Hospital in New Delhi. So he will start our session. Over to you.
Thank you, Dr. Shafi, and welcome Dr. Ashwin Mathur also. She is co-chairing with.
Yes.
Just to modify a little bit, thank you for the kind introduction. Just to add that I have moved on to become director of IBHAS now, Institute of Human Behavior and Allied Sciences, New Delhi, which I took up new role last month only, and moved on from Lady Hardinge Medical College, New Delhi, to Institute of Human Behavior and Allied Sciences in New Delhi. So this is a very important session, and Roop Gushani and me have been working on neuropalliative care to bring palliative care neurologists and rehab physicians in India together. And we did publish in Lancet Neurology last month about neuropalliative care in developing countries, a short commentary. This is an important session in terms of Parkinson disease in India. As you know, this affects more than 300 to 500 persons per 1,000 population in the community, and the elderly population about more than 1% above the age of 65. Usually it's a decade earlier in India, and the average duration of the illness is around 15 to 20 years. The natural history of Parkinson's disease varies from individual to individual. That's one area of research which the researchers are focusing all over the world, why the disease behaves differently in individuals. The Parkinson disease has its different phases, from prodromal to initial honeymoon period to moderate disease to advanced disease, and managing Parkinson's disease itself is a skill, and particularly the advanced disease where all the fluctuations and dyskinesias and falls and so on and so forth are common. But the role of palliative care physicians is becoming now more and more additive to the routine management of Parkinson's disease. And that is why this session was organized to sensitize palliative care physicians and the neurologists about the importance of palliative care in different phases of the disease, and right from the beginning till the advanced form of the disease. So we have two elegant speakers, and I would request Dr. Shafi and Dr. Ashwin to introduce the speakers. I just want to add that we have made learning objectives, which was circulated, and the learning objectives focused on to differentiate between the idiopathic Parkinson's disease and the Parkinson plus the role of palliative care in the beginning to the end of the Parkinson's disease life spectrum, and a little bit of non-motor symptoms, and the role of specialist palliative care in the Parkinson's disease and related disorders, the evidence and practice. So over to Dr. Shafi and Dr. Ashwin to introduce the speakers. And
shall I?
Yes, please.
Okay. Hi. So we have two power-packed individuals in neurology talking to us on Parkinson's today. So exciting. So we'll go straight with Dr. Jessica Baker. First, Dr. Baker is a movement disorder neurologist at the University of Wisconsin. Her special interests are atypical Parkinsonism, palliative care, and communication and neurology. So her topic today is going to be on palliative care across the spectrum of palliative Parkinson's disease. So we're going to be discussing palliative care integration, how to maintain continuum of care, as well as touch a bit on challenges of advanced Parkinson's. So excited, Dr. Baker. We're so looking forward to this. Yeah. So shall we start with Dr. Jessica?
To speak to you today on the palliative care needs in Parkinson's disease and related disorders. Over the next 25 minutes or so, we'll review the diagnosis, management, and prognosis of Parkinson's disease and differentiate it from that of the atypical Parkinsonian syndromes. We'll describe the role of palliative care throughout the course of PD and related disorders. We'll review the supportive management of common non-motor symptoms and describe challenges in the management of advanced PD and related disorders. Parkinson's disease is a progressive neurodegenerative disease with typical onset after age 50. The diagnosis is made based on the presence of core motor features of bradykinesia, rigidity, and tremor, but non-motor symptoms are also a key component of the disease with onset up to decades before motor symptoms. The most common non-motor symptoms are listed in the bottom half of this slide and include constipation, depression, orthostatic hypotension, and cognitive impairment, among many others. In general, motor symptoms are treated with levodopa or other medications that act on dopaminergic pathways. Deep brain stimulation surgery can be considered for the treatment of motor fluctuation or medication refractory tremor. However, some motor symptoms respond minimally, if at all, to levodopa, namely dysphagia, postural instability, and gait disorders, including freezing of gait. Treatment in these cases is largely supportive. In general, non-motor symptoms are treated with medications other than levodopa, and we'll discuss in more detail later in the talk. My key point here is that non-motor symptoms in Parkinson's disease contribute significantly to disease burden, particularly, as you can see here, later in the disease course, and limit quality of life. And that's an area where I think palliative care clinicians can be particularly helpful. One of the challenges in prognosticating in Parkinson's disease is that the disease is very variable from person to person. And the question of prognosis asks not just how long will I live, but how well. And that's a tough one to answer. Dr. Melissa Armstrong has proposed 3 subtypes of Parkinson's disease, which I find helpful to think about from a prognostic standpoint. So in the mildest form of the disease, the mild motor predominant form, individuals may present at a younger age, have mild motor symptoms including dystonia of the foot that respond well to medications. Non-motor symptoms may be minimal, and while others typically don't notice symptoms. This makes up about half of patients with Parkinson's disease. In the intermediate form of the disease, the burden of non-motor symptoms and motor symptoms is moderate, and motor symptoms may respond less robustly to levodopa or may be complicated by motor fluctuations. But individuals are still able to live well and work, particularly if those motor fluctuations can be well managed. This makes up about 1/3 of patients with Parkinson's disease. And finally, in the diffuse malignant subtype of PD, this tends to progress more rapidly. The symptom burden is higher and may include more prominently a gait disorder, dysautonomia, REM sleep behavior disorder, and cognitive impairment. This makes up about 10 to 15% of Parkinson's patients. The mean time from diagnosis to first milestone event, by which I mean regular falls, wheelchair dependence, dementia, or nursing home placement, varies from about 3 years in the diffuse malignant phenotype to 14 years in the mild motor predominant phenotype. Mean time from diagnosis to survival is similarly variable, averaging 20 years in the mild motor predominant subtype, 13 years in the intermediate subtype, and about 8 years in the diffuse malignant subtype. The atypical Parkinsonian syndromes, also called Parkinson's plus syndromes, are neurodegenerative conditions that in many ways mimic the motor and non-motor symptoms of Parkinson's, but overall carry a significantly higher burden of symptoms and a less favorable prognosis. I've highlighted some of the common preference-sensitive treatment decisions in bold. There's a major role here for palliative care in discussing goals of care. Dementia with Lewy bodies presents with dementia often with significant fluctuations in attentiveness and alertness, along with visual hallucinations, Parkinsonism, and cholinesterase inhibitors can be helpful for cognitive impairment. Parkinsonism may respond to levodopa, though this carries a risk of worsening visual hallucinations. Cholinesterase inhibitors can be useful for treating visual hallucinations as well as the atypical antipsychotics, and mean survival from diagnosis is about 5 to 7 years. Progressive supranuclear palsy presents with relatively symmetric Parkinsonism with early postural instability and falls. Dysphagia and dysarthria are often early and prominent symptoms, which prompts discussion of gastrostomy tube placement. G-tube placement in PSP, of course, does not eliminate the risk of aspiration pneumonia. There may be some response to levodopa, though the response is far less robust than in Parkinson's disease, and mean survival from the time of diagnosis is about 5 to 8 years. Multiple system atrophy comes in 2 flavors. The Parkinsonian type presents with relatively symmetric Parkinsonism. The cerebellar type presents with progressive cerebellar ataxia with early profound dysautonomia as a key feature. Cognition tends to be preserved as opposed to the other atypical Parkinsonian syndromes, and laryngeal stridor can develop early at night. This can be treated with CPAP, continuous pressure, but if that's ineffective, one may need to consider tracheostomy for ventilation at night. Levodopa again can be at least somewhat helpful for an often short period of time in managing Parkinsonism, and medications and non-pharmacologic approaches to orthostatic hypotension are also key. Mean survival from diagnosis is about 6 to 9 years. And finally, the cortical basal syndrome is the least common of the atypical Parkinsonian syndromes. It presents with very asymmetric Parkinsonism, often with prominent dystonia and myoclonus. Patients describe an alien limb phenomenon where they've seemingly lost control over one of their limbs. Cortical sensory deficits, such as agraphesthesia, are common. Apraxia, or an inability to imitate gestures or mind-specific tasks, as well as dementia, often a late feature. Levodopa, again, may provide some symptomatic benefit, and survival from diagnosis is about 7 years. And again, I think that the take-home point here is that the atypical Parkinsonian syndromes have a much higher symptom burden than typical Parkinson's disease. They're less responsive to medication, and the prognosis in terms of survival from diagnosis is much shorter, typically on the range of 5 to 10 years. So what is the role for palliative care in Parkinson's disease and related disorders? And in my opinion, there's a role for the palliative care skill set throughout the entire course of the illness, and it waxes and wanes a bit depending where along the trajectory we are. I've highlighted some of the common palliative care needs and the approximate time that they might come into play above, and we will discuss some of these palliative care needs in more detail throughout the remainder of this talk. This figure is from a survey of about 600 patients with Parkinson's disease describing the prevalence of various non-motor symptoms, and I find these results just astounding. So for example, nearly 90% of respondents described having fatigue, with almost half of them describing it as uncontrolled. Other common non-motor symptoms include pain, constipation, insomnia, anxiety, among many others, and we will discuss the management of some of the more common non-motor symptoms over the next few slides. Fatigue is very understudied in Parkinson's disease compared to the degree of disability it causes, And there are two key points here. One is that it's important to differentiate fatigue from conditions that can mimic fatigue and might have very different underlying causes. And it's also very important to rule out secondary causes of fatigue. So fatigue can affect up to half of patients with Parkinson's disease and has a negative impact on quality of life. Patients with fatigue may have trouble with work, or they may avoid hobbies or social activities due to fatigue. Fatigue is defined as a lack of energy or an increase in the effort required to complete certain and mental tasks, not improve rest. It is distinct from apathy, which is described as lack of motivation, excess daytime sleepiness, including easily falling asleep, needing a nap, and depression. Left untreated, fatigue can lead to withdrawal from physical and social activities as well as employment. So in the evaluation, it's important to rule out secondary causes. So for example, fatigue can be a side effect of medications, including beta blockers and at times dopamine agonists. Orthostatic hypotension can present with fatigue. Sleep disorders such as insomnia and obstructive sleep apnea we often think of as causing excess daytime sleepiness, but can also cause some fatigue. Symptoms such as dyspnea and exertion, chest pain, or palpitations should raise the possibility of a non-neurological cause of fatigue, including cardiopulmonary dysormia, metabolic abnormalities. So in general, I would recommend checking a comprehensive metabolic panel, complete blood count, and at a minimum thyroid studies in individuals before assuming that fatigue is in fact due to Parkinson's disease. So how can we treat fatigue in Parkinson's disease? Unfortunately, all of these interventions have little or no evidence, but in clinical practice have shown themselves to be at least somewhat helpful. So in terms of non-pharmacologic approaches, we usually recommend exercise as first line, typically up to 150 minutes a week of moderate intensity exercise, which could include something as simple as a brisk walk. Energy conservation strategies, including saving the most taxing tasks for the times of day when you tend to feel best when your medications are on and working, can be helpful. There's some evidence that acupuncture can be helpful, and in folks that are already drinking caffeine, adding 1 or 2 cups of coffee a day. In terms of medication, the MAO-B inhibitor selegiline has amphetamine metabolites and can be helpful with fatigue. We usually avoid giving the second dose after about 2 p.m. to avoid worsening insomnia. Stimulants such as modafinil and methylphenidate can also be helpful for fatigue, but should be used cautiously in individuals with cardiovascular disease, and certain jurisdictions may have limitations on indications for prescribing those medications. And finally, amantadine is reasonably well tolerated, but its use can be limited in the elderly by sedation, cognitive side effects, and also worsening of visual hallucinations. Many individuals with Parkinson's disease describe pain as their most functionally limiting symptoms, and it can affect up to 80% of individuals with PD. There is no consensus classification on pain in PD. But some of the buckets include PD-related versus unrelated. Pain can be described as musculoskeletal, dystonic, radicular, peripheral, or central. It can be acute or chronic. The nature of the pain can be nociceptive or neuropathic, and it can either respond or not respond to dopaminergic medications. The King's Parkinson's Disease Pain Scale has been validated for use in Parkinson's disease and asks the patient to rate their pain over 7 domains, which includes musculoskeletal pain or pain around joints, which includes arthritis, chronic pain, pain related to fluctuations, including dyskinesias and off-state dystonia, nocturnal pain, which includes pain related to periodic limb movements and or restless leg syndrome, or facial pain, discoloration, edema, and swelling, as well as radicular or neuropathic pain, including pins and needles. A practical approach to assessing and managing pain in Parkinson's might start with establishing whether or not the pain is related to motor fluctuations. If that's the case, you may try to optimize dopaminergic therapy first. The rotigotine transdermal patch can be particularly helpful for reducing fluctuation-related pain at the end of each dose and also early in the morning. Pain can also respond to deep brain stimulation. On-state dystonia, which can be difficult to treat, can respond to botulinum toxin injections as well as treatment with anticholinergics and baclofen. As the next step, you might ask if the pain is related to underlying osteoarthritis, which tends to be very common in a typical Parkinson's disease. This can be treated with over-the-counter medications, including NSAIDs such as ibuprofen, acetaminophen, and in some cases, physical therapy. If there is a neuropathic component to pain, there are several classes of medications that can be particularly helpful, and these are the same cast of characters that you might use to treat neuropathic pain in other situations. So the SNRIs, including duloxetine and venlafaxine, tend to be very well tolerated. Alpha-2 delta ligands, such as gabapentin and pregabalin, can also be very helpful. Tricyclics are great for managing neuropathic pain, but the side effect profile tends to be less favorable in our patient population. Pain that is located at the base of the neck and the shoulders is called coat hanger pain, and that is often a sign of orthostatic hypotension, which should be evaluated and treated separately. Constipation affects at least 90% of individuals with Parkinson's disease and is often present in the prodromal phase, years or decades before the onset of motor symptoms. Symptoms of constipation can include difficulty passing stools, infrequent stools, typically fewer than 3 bowel movements per week, as well as abdominal bloating, cramping, and at times nausea. The cause of constipation is multifactorial. It is certainly intrinsic to Parkinson's disease, but may be exacerbated by medications, including those used to treat PD, among others. Diminished mobility in those with a high burden of motor symptoms, as well as decreased fluid intake and an attempt to minimize urinary frequency, can also contribute to constipation in patients with PD. So how can we treat constipation in Parkinson's disease? First, eliminate exacerbating medications if possible. Common culprits in our patient population include anticholinergics such as trihexyphenidyl, amantadine, and antiemetics such as ondansetron. Opioids, typically prescribed for reasons other than PD, can certainly exacerbate constipation as well. If eliminating exacerbating medications is insufficient, one can consider non-pharmacological and lifestyle interventions. Increasing physical activity, promoting hydration, and counseling on the importance of avoiding diuretics such as caffeine and alcohol may help with constipation. Of course, these interventions may require optimizing treatment of motor symptoms and urinary frequency. Avoiding elevated toilet seats and using a small stool to raise legs may create a more natural position to facilitate elimination. Dietary changes are key in avoiding constipation. Individuals with constipation should be counseled on the importance of a high-fiber diet, including fruits, vegetables, and whole grains. Bulking agents such as psyllium, guar gum, and methylcellulose may worsen constipation if not taken with sufficient fluids. Randomized controlled trials in PD have demonstrated that multi-strain probiotics are effective in increasing the frequency of spontaneous bowel movements, stool consistency, and quality of life related to constipation. If eliminating exacerbating medications, lifestyle, and diet changes are ineffective in treating constipation, we're left with many of the same tools used to treat constipation in the general population. I've listed some of the most commonly used agents here. Osmotic laxatives draw water into the GI tract, resulting in softer stool. These may cause bloating, but are usually well tolerated. Stimulant laxatives increase colonic motility. Senna is often available in combination with the stool softener docosate. Bisacodyl can be given as a suppository. Chloride channel activators increase intestinal fluid secretion and accelerate GI transit. There is some evidence supporting the use of lubiprostone in Parkinson's disease, but I rarely use these in my clinical practice. Mood disorders are a major cause of diminished quality of life and caregiver burden in PD, with depression affecting at least 1/3 of patients, anxiety in upwards of half, and apathy in about 60%. Include female sex, more advanced disease, and cognitive impairment, and it's worth noting that this may also occur as an off-state phenomenon as part of non-motor fluctuations. The approach to treating depression and anxiety in individuals with Parkinson's is very similar to that of the general population. SNRIs such as fluoxetine or citalopram, SNRIs such as duloxetine and venlafaxine can be helpful for both depression and anxiety. SSRIs are usually well tolerated, but there is a risk of drug interactions. Sexual is a common side effect. SNRIs, as we've discussed, can also be very beneficial in the treatment of pain. Tricyclic and use limited in this population, mainly by side effects. There's some evidence that the dopamine agonist pramipexole be helpful for depression, and mirtazapine we know in palliative care as a jack of all trades, helpful not just for depression but also insomnia and decreased appetite, and there may be some benefit to the tremor in Parkinson's disease as well. Cognitive behavioral therapy is an effective treatment for both depression and anxiety, and I would caution you on the use of benzodiazepines, namely for the risk of worsening cognitive impairment and falls in this patient population. So lastly, I'll switch to a discussion of some of the challenges in managing advanced Parkinson's disease. For the purposes of this talk, I'll define advanced Parkinson's disease as being functionally dependent in activities of daily living. The prevalence of dementia is as high as 60% at 15 years and 85% at 20 years in patients with Parkinson's disease. Psychosis is characterized by both visual hallucinations, which are typically well-formed and described as benign, but can in fact be quite scary, as well as delusions. Delusions of spousal infidelity tend to be particularly common. Insight is variably retained. Dementia and psychosis contribute significantly to caregiver burden and dementia is in fact the strongest predictor of nursing home placement in the Medicare population in the US. The first step in treating psychosis in PD is first making sure that you've evaluated for underlying causes. For example, if the symptoms are relatively acute onset, checking for urinary tract infection. The first line of therapy includes behavioral interventions, so it's important to note that we only need to act on hallucinations that are intrusive to the patient or to caregivers. Caregivers should respond honestly when asked if they've seen the hallucination, while at the same time validating its reality to the patient. If those non-pharmacologic and behavioral approaches are ineffective, we can next reevaluate certain medications. So anticholinergics, dopamine agonists, and amantadine may all worsen the symptoms of psychosis. And if needed, it is important to revisit the benefits and burdens of levodopa, which of course can be very helpful for motor symptoms, but can also worsen psychosis. So in advanced disease, it's not uncommon to taper levodopa. I would generally avoid stopping it very quickly because of the risk of an NMS-like syndrome called the Parkinsonism hyperpyrexia syndrome. And finally, if behavioral interventions, reevaluation of medications are ineffective in managing psychosis, we can add additional agents. Cholinesterase inhibitors can be helpful for visual hallucinations. Atypical antipsychotics such as pimavanserin, quetiapine, and clozapine are helpful, but quetiapine and clozapine do carry an increased risk of cardiovascular events and death when used in individuals with dementia. Typical antipsychotics such as haloperidol can worsen motor symptoms and should absolutely be avoided in advanced Parkinson's disease. Behavioral problems in advanced Parkinson's disease tend to go hand in hand with dementia. Common behavioral symptoms include anger, irritability, agitation, and aggression. And as I'm sure you can imagine, these symptoms can cause significant strain on care partners. As a first line, address and evaluate any underlying pain, hunger, or thirst, as well as constipation or urinary retention. Consider whether agitation may be a wearing off phenomenon or potentially a side effect of medications. Certain symptoms such as hypersexuality or overeating may be signs of an impulse control disorder, which can be seen with dopamine agonist use. If those steps have failed to address the behavioral problems, SSRIs and perhaps cholinesterase inhibitors can be tried. Benzodiazepines and antipsychotics are considered a last resort. Benzodiazepines, of course, carry an increased risk of falls, and antipsychotics, again, carry significant risks in the dementia population. I've listed some of the common preference-sensitive decisions in advanced Parkinson's disease here. There is certainly a role for palliative care in discussing goals of care in these situations, ideally before the development of cognitive impairment and with the involvement of a patient's surrogate decision maker. So dysphagia is the rule in advanced Parkinson's disease. It's a common cause of hospitalization and death. And a question that often comes up is whether or not one should place a gastrostomy tube or manage more conservatively with perhaps a modified diet or maneuvers that minimize the risk of aspiration with food. Some patients, of course, may choose to eat for comfort and accept the risk of aspiration that comes along with that. And again, we know that G-tubes do not eliminate the risk of aspiration from saliva. Patients will ultimately have to make decisions about their preferences for resuscitation in the event of cardiac arrest, as well as treatment of infections such as urinary tract infections and pneumonia. Care in that case could range from hospitalization, which could include intensive care and intubation if needed, versus a more palliative approach at home, including oral antibiotics, or perhaps simply comfort care or symptom management. And patients may also express a preference for the place and mechanism of care through the end of life. Most patients with Parkinson's in the US prefer to die at home, but unfortunately most die in a hospital or in a nursing home. I'd like to say a few words about caregiver experience at the end of life. So this is a survey of US caregivers for patients with dementia with Lewy bodies. And I just found these results so remarkable. So only about 40% of caregivers recall discussing expectations for end-of-life care with a physician. This was usually done at the request of the caregiver, and of those that discussed, only about half actually found it helpful. Less than 50% of caregivers felt prepared for what to expect at the end of life, despite hospice involvement in a majority of the patients. And the conclusion I take from this is that there is a tremendous amount of room for improvement in the way that we as neurologists and palliative care clinicians counsel patients and families on what to expect at the end of life. So to summarize, the prognosis in Parkinson's is variable, with survival from diagnosis ranging from 8 years in the most malignant form of the disease to 20 in the most mild. Atypical Parkinsonian syndromes or Parkinson's plus syndromes have a higher symptom burden and a less favorable prognosis than typical PD. There is a role for palliative care in various capacities throughout the entire course of Parkinson's disease. Non-motor symptoms such as fatigue, pain, constipation, and mood disorders contribute significantly to disease burden. Dementia, psychosis, and behavioral symptoms are common in advanced PD and contribute substantially to caregiver burden. Common preference-sensitive treatment decisions should be addressed prior to the onset of cognitive impairment. My references are included here. I thank you for your attention today during our live session. Thank you.
That was wonderful. Thank you so much, Dr. Baker. I think that was a real summary of exactly how challenging palliative care and neuropalliative care can be with in Parkinson's disease, and it was a very thorough, update for us on all the challenges and the symptoms, and especially fatigue being such a burden. And I think it was also quite interesting how the end of life discussions are also challenging in Parkinson's as well. So that was really, really wonderful. Thank you so much for that. Next, shall we move to the next speaker? Another power-packed speaker for us today, Dr. Zachary Machi. He is an aging and palliative fellow at the University of Colorado. Neuro care, which is obviously from last speaker, how important it is and under practiced. And his area of interest is particularly in Alzheimer's and Parkinson's. And today he's going to be talking about the role of specialist palliative physician in Parkinson's. And we're going to be versus in neuropalliation. Yes? Shall we start with Dr. Zachary's?
At my fellowship this year. And so I wanted to take the time today to talk to you about the role of specialist palliative care in the treatment and management of Parkinson's disease and related disorders. So we'll be looking at evidence as well as models for practice and how those can be implemented in various scenarios. We'll examine why these conditions owe themselves to a palliative care approach, and we'll look at models and approaches for outpatient palliative care in Parkinson's disease. We'll also look at the evidence for integrated outpatient palliative care as one model or approach for specialty. So to briefly talk about what do I mean when I say Parkinson's disease and related disorders? So this is a group of conditions that is hallmarked by overlapping and diverging symptoms and issues. Most commonly, this would be idiopathic Parkinson's disease, which has quite a footprint in the world in terms of its effect on mortality. You can see a graphic to the right there showing the estimated deaths per million persons across the world due to Parkinson's disease. So as you can see, it's a very widespread issue, especially if we're even only looking at mortality, let alone morbidity and the financial burdens of this disease. But we also include conditions like dementia with Lewy bodies, which is actually the third leading cause of dementia worldwide, as well as progressive supranuclear palsy, multiple systems atrophy, and Huntington's disease. And these conditions are hallmarked by a combination of motor and non-motor symptoms and manifestations. Typically, the motor symptoms were the most commonly recognized related to these conditions, and those can manifest as excessive movements. So we think of tremor, increased muscle rigidity and dystonia, as well as abnormal involuntary movements such as chorea, and all the way to a deficiency of movement. So in Parkinsonism, you get slowness of movement, difficulty initiating movement, and this can manifest as gait disturbances, problems with posture, frequent falls, as well as difficulty using the limbs for basic tasks. And then also a problem with control of movement. So we think of ataxia as being one of the most common manifestations of this type of motor symptom. What's becoming increasingly recognized amongst these conditions are the non-motor manifestations. And there's actually been a movement to recognize these in greater detail, specifically because they have significant implications for functionality for patients, as well as issues that can arise. So we think about things like neuropsychiatric symptoms, psychosis, hallucinations, mood disturbances like depression and anxiety, as well as apathy and fatigue. All of these are very common in PDRD, especially so much that in dementia with Lewy bodies, for example, hallucinations, visual hallucinations, are actually a core feature of the disease. Now, all of these can have some form or degree of cognitive impairment, where 80% of patients with Parkinson's can go on to develop some form of dementia, but then also fluctuations in cognition for individuals who might not necessarily otherwise meet the level of dementia, but have wide variability in their cognitive function, to where you get wide fluctuations on the order of minutes or even hours, sometimes days. And this is another core feature of dementia with Lewy bodies within the group of conditions we call PDRD. Autonomic symptoms like orthostatic hypotension and gastrointestinal disturbances can also be seen. And pain, significant physical discomfort, can also be seen as a manifestation of the motor and non-motor symptoms. Now, what is the rationale for palliative care? As I've mentioned, there are a number of things that these conditions have, issues that they create, that are very complex. And in so, these patients have very high palliative care needs based on their physical symptoms, their psychological symptoms, but then also the psychosocial problems that can occur related to being able to hold a job or manage a household, and that can manifest as financial hardship or distress. And then there's the reaction to the disease itself, can be incurred over time as the disease progress. And so patients can react to them much in the same way as people who are going through grief and bereavement experience. And grief is actually one of the things that is more commonly missed in these individuals in their management. But you can see that these individuals require a multifaceted approach to their care. They are receiving care from multiple providers usually, not necessarily in an integrated way. And as such, they can also experience other reactions to illness, and that can include spiritual and existential distress. And I've included a graphic here to show the number of individuals that a patient might, not just their neurologist, but also their mental health, a pharmacist, speech therapy, physical therapy, social worker to address each of these issues. And so the impact, and also the of these conditions extends well beyond the patient, can affect the care partners and families of individuals. So much so that research that's looked at caregiver burden in Parkinson's disease has actually found it to be comparable to other types of neurologic illness, including things like stroke. But care partners and families can experience substantial burden, and they are forced to cope with these as time goes on. They can see changes in family dynamic or interpersonal relationship issues as care partners are taking on more and more responsibilities as the disease progresses. And they can also experience significant burnout. These are long, protracted illnesses over many years in cases, and care partners can experience the stress and burden of these diseases over time that actually highly correlates with patients' disability, so as the disease progresses. So much so that the care needs of care partners is actually comparable to the patients themselves. And care partners can experience increasing mental stress and depression because of it, as well as self-described poor quality of life. And so the rationale for palliative care makes complete sense when we think about the effect of this disease on the individual, so much so that it falls very much in line with what Cecily Saunders, the founder of the modern hospice movement in the 60s, termed as total pain. So the big picture or all-encompassing perspective of an individual, the physical, emotional, social, and spiritual dimensions of distress that can be experienced over the disease course. And in doing so, these conditions owe themselves to a palliative care approach. Now, when do we think of indications for palliative care in these conditions? So with these diseases, there is a change over time, with periods of low burden disrupted by periods of high needs and high disease burden. And so we see that over time. This can be hallmarked by what we call sort of landmarks along the roadmap of the disease. This can start as early as when the person gets a diagnosis, as they're coping with or understanding the diagnosis and how it affects their day-to-day life, thinking and planning for the future. But then as time goes on, they appreciate increasing needs as they have loss of ability, whether that's for things like driving or living independently, all the way to when activities of daily living that are basic for individuals, thinking about dressing, feeding, toileting, become affected too. And then as time goes, accelerated decline as patients near the advanced stages of these diseases, all the way to the time of death and the end of life. And the palliative care needs do not stop when the patient dies. It actually, the experience of going through this for the individuals who were supporting them, so the care partners, is also an indication for when palliative care might be helpful. So helping care partners, families go through bereavement. To individuals who have these diagnoses, and looking at, well, when should we think about referring them to a specialized palliative care provider or group? And so one approach is to think about it in terms of those triggers, so those landmarks on the roadmap of these diseases. And this can be a way that this can be framed for discussions with patients and care partners, when a rationale for having a conversation about when should we discuss getting palliative care involved. And in general, that could be things related to like the new diagnosis, caregiver distress, or accelerated progression. If we look at specific conditions within PDRD, Parkinson's disease as being an example, when it comes to severe motor symptoms, or when medications become refractory in their ability to help motor symptoms, or if we're starting to see nutrition by way of dysphagia or problems swallowing, or advanced dementia. In dementia with Lewy bodies, if we're seeing impairments related to visual hallucinations, frequent fluctuations in cognition, those might serve as triggers for discussing palliative care. Huntington's disease with the inability to maintain nutrition, or severe neuropsychiatric symptoms also owes itself. Now, PSP, or progressive supranuclear palsy, and multiple systems atrophy also have a couple symptoms and issues that might owe itself to a palliative care approach or referral. For PSP, that could be frequent falls or immobility. With MSA, or multiple systems atrophy, that could be related to problems surrounding autonomic symptoms, so orthostatic hypotension, or even breathing, respiratory issues, which unfortunately become common in MSA as the disease progresses. We can also look at the need for referral to palliative care based on the use of needs assessment tools. So these are tools that exist to identify and triage different domains in patients and caregivers. We think of it in terms of whether it's physical deterioration or complex symptoms, weight loss and dysphagia, problems with respiration or aspiration pneumonia with frequent or reoccurring pneumonia, cognitive decline and advanced dementia. And this might involve the use of checklists, scales, or just the overall general clinical impression from providers, looking at motor and non-motor symptom severity, other needs that expand beyond those, and then also care partner burden. And so there are specific measures and scales. Now, there are various models of specialized palliative care that have been studied in PDRD, and I'd like to go through those in more detail here in a moment. But number one is the consultative model, which looks at palliative medicine specialists who provide care in addition to the patient's neurologic care, so through their neurologist. There's the integrated model, where palliative medicine specialists are actually integrated into a neurology practice. And then there's the subspecialty neuropalliative model, where patients actually are cared for by providers with specific training in both palliative medicine and neurology. Let's take a look at the consultative model, which is more common in Europe. And as I mentioned, this consists of a consulting team, a palliative care team that usually consists of multidisciplinary providers, and they work with a primary care physician or who's providing routine care to these patients. And this is purely based on a referral basis, and it's purely a consultative type position where the palliative care team doesn't necessarily take over the care of the assists the primary provider. And this has been studied. The research that's looked at this has actually used in the UK and in Europe. Look at the effect of immediate referral, delayed referral versus standard care. And this came out in 2007, any PAL study. Significant differences when they looked at groups. So those randomized treatment arm noticed improved quality of physical symptoms, pain, dyspnea, and sleep disturbances, as well as GI changes that were clinically relevant, meaning there was a great 20% change in these for those who were randomized to the immediate arm. Palliative care is something that we should not necessarily delay, but actually there might be as we see these issues and triggers arise. Now, the integrated model, which is more common in North America, is modeled on the idea that you have a palliative care specialist integrated into a neurology clinic. So working with neurologists who are not necessarily trained in palliative care, but adding to the care that they receive in this clinic by having a palliative care point person. This was pioneered by Janice Miyazaki in Alberta. And what they showed in their preliminary study was that there was a benefit for at least symptom burden in advanced Parkinson's disease. Benzie Kluger, here at my own home institution, now working at the University of Rochester, took this to the next level by performing a randomized clinical trial of integrated outpatient palliative care for PDRD. And what they showed was that there was a significant benefit measures of high quality palliative care, one of those being increasing advanced. Now, the third and final model, which is actually the specialized neuropalliative patients get care from a provider as well as a with experience and training in both neurology and palliative care, has been kind of a newer adopted here at my home institution at the University of Colorado by Dr. Christina Vaughn. Disorders. And the caregivers and families and chaplain services. And we're actually in the process of planning for a way to embed sort of a representative across other types of neurology clinics at our institution as a way to sort of augment the care that this clinic is being provided, knowing that these patients very commonly have more than one neurology provider when they go to be seen at the neuropalliative and supportive care clinic. Now, if we look at comparisons of these models, you can see that when we put them side by side with what we consider to be primary palliative care, which is a palliative care approach that's adopted by someone who is not necessarily trained in palliative medicine, so whether a primary care physician or a neurologist, that there are strengths and weaknesses. of course, some of the limitations that I wanted to point out are present. So especially when it comes to access and availability of providers, especially when you think of neuropalliative specialists, a very small group of individuals who have this training. And that's been a focus of training programs across at least the US to improve the way that we train neurologists in palliative medicine for those who are looking to pursue a career in this. The consultative model, which is specialty palliative medicine, palliative care, which is not focused on neurologic issues, but rather broader sort of palliative medicine, especially when it comes to prognostication. These are individuals who might not necessarily have a background or knowledge of palliative medicine as it pertains to Parkinson's disease. In that way, can be a limitation if you compare it to getting focused neuropalliative specialty care. And there are some emerging trends in the way we deliver palliative care. Home-based care, which of course, home hospice has been something that's been adopted by palliative medicine for a long, long time now, but we're seeing its utility in Parkinson's disease, where it's been shown to be feasible, and there is an improvement in quality of life despite symptom progression in the studies and research that's been done looking at home-based palliative care for Parkinson's. Additionally, telemedicine, especially in the era of COVID, has become an expanding way to deliver palliative care, especially for those who are immobile or homebound. And it's been identified as a principal method for possibly expanding palliative care in PDRD. Of course, it has its limitations. Now, when it comes to hospice and end-of-life care in Parkinson's disease and related disorders, there are specific triggers. We have here in the United States Medicare guidelines for when hospice is appropriate. And I've listed here, I won't go into much detail, but there are specific things that PDRD owes itself to that are issues that might be triggers for hospice. So especially when we consider severe dementia or severe neuropsychiatric symptoms, treatment refractory motor symptoms, dysphagia, and especially in MSA, which can be difficult to manage, but are certainly owing themselves to a palliative care approach. Of course, one of the things that research is trying to look at in terms of how can we better implement palliative care worldwide are the issues related to access. So it's very difficult to have a neuropalliative specialty model when you don't have a whole lot of neuropalliative specialists. So finding a way to either adopt the consultative model or integrated model as an alternative might be the way to go as we continue to research ways to get better access. Communication between providers, especially when it comes to the consultative and integrated models, are also barriers. As well as preconceived perspectives of palliative care amongst patients, families, and referring providers. And of course, the unpredictable nature of these conditions makes it difficult to understand when and how Parkinson's disease and related disorders. And here are some of my references if you're interested in looking at some of these studies that I've mentioned as well as others. And I'd like look forward to any questions.
Thank you so much, Dr. Zachary. That was wonderful. It's becoming very, very clear how important it is to integrate palliative care as soon as possible, especially since it does have a long need a multidisciplinary that was really wonderful. Thank you so much. We can have the next session as
thank you, Jessica and Dr. Machi, for the wonderful elaborative lectures, and they were really educative and informative, and it will go a long way in palliative care movement in India. As you know, neuropalliative care is my one question to Dr. Jessica Baker is that what is being a potential with the family and caregivers and
at the very beginning of the disease, just life-changing, I think, is the first conversation.
expectancy after the diagnosis is relatively on right from the point of view of palliation.
Effects that has on not just the patient, but the patient's family. Patients with delusional disorders who maybe those are a couple examples of when I think a palliative care approach is really useful, because unfortunately, the current state of the way we take care of clinic is there is the time to sit down with experiencing we can do to help support the caregiver. Those tend to be the scenarios where I find care scenario adopting a palliative care approach, and that's just something that I folks who aren't necessarily seeing a palliative
specialist care. In a for us treating these patients, there are very few people who are really interested in on board.
The big barriers access to specialists. You know, I model where some the best way to go until we have access and more specialists. Simply because if we can educate clinicians on specific core parts of palliative care, then they might be able to at least includes, you know, focusing on things like advanced care planning, as well as, you know, caregiver. We have more specialty palliative care and neuropalliative care specialists. Simply their own practice, I think, is likely the way to go to supplement in the meantime.
Specialist.
Hub primary palliative care, you know, whether it's supporting them in terms of education and not, so that at least
Shafi, can you just read it? You are muted.
area of emergency limitations and but you know, in the as the needs assessment tool in Parkinson's disease. Again, more research is needed to validate this as an example, but essentially related to palliative care needs, symptom burden, caregiver burden, as well as other. And so the needs assessment tool in Parkinson's disease probably have right now caregiver burden or burden inventory, caregiver burden, as well as the ESAS-PD motor and non-motor symptoms. So those are a few examples. We don't have one universal need. The situation is, or what sort of needs are identified.
I think just to add to that, there is a Edmonton symptom assessment revised these days, and I think it has been validated also. Is that correct? My understanding?
So it has been validated. It's also gone through. Specifically, is that it does capture a lot of the non-motor manifestations of disease, which I think is, you know, we're learning more and more about the role that those symptoms play in in overall disease burden. However, there's still a lot that needs to be done to educate folks on the fact that this is something that occurs in these diseases. So that's one of the things I like most about that measure in particular, because I think in routine care, we do sometimes miss or not think about some of those non-motor manifestations of disease, simply because they are harder to pick up on, things like apathy, fatigue, and they also can overlap with other problems.
Do we have time for one more question?
Yes, please go ahead for the last question.
One last one from Dr. Roop again. Both individually.
'22. Forward to time in person.
Thank you.
Yeah.
Thank you.
Bye-bye. Thank you. Good night.